This is FX Medicine. I'm Andrew Whitfield Cook. We're at the 2019 UIC Medicinal Cannabis Symposium. I'm speaking with Adam Miller from Pharmacare Laboratories. Adam, how are you?
I'm very well, thank you.
Adam, there's been a lot of different talks, many angles, science, policy, personal access. Where does Australia stand in the stage compared to other countries? And should we be comparing, should we be including with regards to medicinal cannabis?
Yeah, well, I always find that comparisons are a useful tool to kind of gauge progress and to assess where strengths and weaknesses lie. Australia, in theory, has a system that works. Patients can access medicine. But when you break it down into the individual parts within that framework, it's quite broken, convoluted, and relatively underthought with how patients can gain access to these medicines. And what I mean by that is the doctors are undereducated, they're under-resourced, they don't have a lot of time, and yet they are being asked to fulfill quite a lengthy process to allow patients to access a medicinal cannabis product. And what's worse is they are not informed as to how to prescribe and how to maintain the patient's progress on that cannabis medicine. So no dosing information is being provided or taught to these doctors, nothing about titration. So they're really quite vulnerable, which means that patients are vulnerable. If you look overseas to Israel or Canada, for example, there's a comprehensive history that they've developed through trial and error on how to best prescribe cannabis to patients. And in Israel, more than 50,000 patients or so have been given access, and not one person has died. We can learn from that. We can integrate that knowledge into Australia, but it's not being done. And the ones that are suffering are the Australians. And in about 2.5 years, we've seen about 3,500 patients being approved, which is a great start. But if you compare that to Germany, for example, which in its first year, more than 14,000 patients were given access to a medicinal cannabis product, we're failing in comparison.
Vice versa, you've got the UK system.
Yes, 4 patients have been given access to.
In what time period?
In about 2 months, 3 months.
Right, 4 patients.
4 patients.
Let's say 20 odd per year. And then compare that to, you said Germany was 13,000?
14,000 in the first year.
And Canada?
Canada right now, in Canada it was less than 200 in their first year, but that was almost 2 decades ago. Now the patient population is sitting at about 330,000 in Canada. Mm-hmm. So, they've got a sizable patient demographic. They also have a black market. I mean, not a black market, a regulated adult use market. So there's a good split of people that are using it for their own personal use, as well as patients that are using it. And what I find is interesting, in Canada, patients are allowed to grow their own plants, up to 100, but about 1% of the market actually do that. So it shows that there is a need for patients that are in search of medicine to go to a company that has the expertise and knowledge to grow that medicine for them. And I think there's room for all of these facets of the industry, but they're not being utilized here in Australia as yet.
Indeed, Mark Ware was talking about that earlier with regards to how the youth are not taking it up as it was thought they would. Indeed, it's flattened off, whereas the major units are indeed the elderly, the ones with chronic disease.
Yeah.
You mentioned something just before, adult use.
Yeah.
Now, is this something that we're shirking away from a term, or we're trying to find an inclusive term? Because obviously there's children that require certain cannabis products for epilepsy control. So what are we do? Are we just dancing around a term here?
Cannabis use. You can just call it cannabis use. There is pediatric cannabis use, children that are suffering from epilepsy, children with autism, even with ADHD. There is a small amount of research into ADHD, and I won't go into that, but there could be a future use of cannabis for children with ADHD versus the typical Ritalins or Concertas or dexamphetamines, which are amphetamines. And although there's a relatively safe safety profile, we don't know what that is compared to cannabis. So I think that we shouldn't call it adult use. But adult use is actually the reference for a recreational market. So
right.
So when I say adult use, I'm actually trying to veer away from recreational and kind of empower people to call it what it is. It's an adult use system like alcohol.
Yeah.
Alcohol is not a recreational market per se. It is a system where adults can choose to inebriate themselves with a product that has been regulated. And what I find very interesting about cannabis and alcohol, if you go back to Prohibition period in the 1930s or prior to the 1930s, you know, you've got characters like Al Capone who were infamous in the Prohibition period, and there were turf wars. People were going to war over alcohol. People were getting killed. You don't see that today with bottle shops.
No.
You don't see bottle shop turf wars, but you do see that in the cannabis and illicit drug market space. People are getting killed because drugs are still deemed illegal. So it is kind of opens up a greater conversation to what I personally look at cannabis as what I call the Trojan horse of sovereignty. It is kind of illuminating the fact that the drug war has failed. It puts patients in a position where they are vulnerable, where they have to go to a black market, which has no safety controls, which have no quality control measures, and you could be very likely in some cases dealing with a snake oil salesman. So I want to reference this because I've been thinking about it over the last week. I am not for the black market. I don't believe there should be a system where patients are vulnerable in any way. But I'd like to separate the black market from the black market being the illegal market, the white market being the legal market, the regulated market, and then the compassionate market, which is people who are putting their lives in danger to supply patients with a medicinal cannabis product that can assist them with their symptoms or sicknesses. So I feel that we should be empowering the compassionate market while the industry is still in its embryonic stage of development.
So of course you've got issues with both the white market is heavily assessed, controlled for a specific product. The issue there is cost that we've seen. Then you've got, the black market. We know those issues, and then the white market, compassionate market, is sort of somewhere in between. But there are still those issues of quality control, pesticide residue testing, all that sort of thing. Does that get done in that compassionate market?
Unfortunately, I can't comment on that in its entirety. I know compassionate growers that do their own chemical analysis testing, but they would be the minority, I would imagine, not the majority. And if any compassionate compassionate grower had the ability to test their product, I'm sure they would. And if they had the protocols to grow in an environment where they could minimize the pesticides or the potential heavy metals or even the water that they're using, because if it's not organic water, there may be other contaminants. I mean, they would. I guess they're doing the best with what they've got. And again, patients become vulnerable because they don't have access to something that they know is going to be quality consistent batch after batch, because it's a volatile plant. If you grow it in one environment compared to another environment, even if it comes from the same clone, it's very likely, if it's grown in different environments, they'll have different chemical compositions, chemovars, different chemical compositions. So, medicine is designed to be consistent batch after batch, and patients are, unfortunately, therefore not potentially getting the best of what we could offer, because the government just isn't allowing the industry to go at a pace that is acceptable.
Israel is doing this. Israel, it's still an illicit drug, but for medical access, it's just like there are these products out there, and it's not one, it's not 10, it's not 20. We're talking hundreds, which Dedimieri was talking about. And his expertise, his knowledge, allows him to have some direction in this group of cannabis products would be more likely to help that condition, whereas the other one would be more likely to help another condition.
And imagine what we could learn from our compassionate growers who have treated thousands and thousands and thousands of patients if we gave them the platform to come out of hiding and to work with the growers in a compassionate scheme that doesn't criminalize them for being human.
Yeah, and did you see this? There's a great website, leafly.com. It's an American supplier, I understand. Is that right?
No, they're more of a kind of a holistic website that looks at the products that are available on the market. So they'll, whatever the product is, they'll do a review, they'll ask their users to do a review, and they're just providing information to the people, and they'll also have independent write-ups on how cannabidiol, one of the articles I read recently is, cannabidiol and anxiety, and it explores how cannabidiol might be effective to treat anxiety, which there is good research to support that. For social anxiety, there is some research that suggests that CBD can be quite useful for treating anxiety. Still early stages, but a lot of anecdotal evidence would promote and support that agenda or that topic and piece.
What I love about that website is that it shows the breakdown of not just the CBD, THC, which we commonly get caught up in, and particularly this THC, it's worrisome. CBD, no issue with impairment. So you're talking about social anxiety, no issue with impairment. But importantly, that we require these terpenes, this terpene spectrum, which obviously, I can understand a doctor having real issues with this because of it goes back to education.
Yeah, of course.
So therefore, what are the sort of plans? What are the hopes for the future with educating the Australian medical profession?
Yeah, that's a tough one. I recently attended a specialist gathering where one of the licensed producers presented their findings, and it was all THC CBD. And one of the doctors kind of called them up on that and was trying to understand and wrap their mind around how can THC and CBD in these different ratios actually be effective, and trying to dig into the efficacy of it. And what I felt was a challenge around this is that because we're not having the conversation about the terpene profiles and the entourage effect, we might actually be doing a disservice to doctors that are savvy and are going to drill us on the research. And if we are going to say, yes, in these instances, cannabis, CBD and THC are it's the plethora of focus. In the future, when we introduce these other terpenoids and these other cannabinoids, it might actually veer them away and lose confidence with them, because we're talking about just two constituents of a plant that has 700 plus compounds present in it. So I think that for the pursuit of in the pursuit of education, we need to start thinking about how do we want to educate people on what's available, THC, CBD, one-to-one, etc., but also explaining how cannabis is a multifaceted medicine. It is not so, single-dimensioned with, one single molecule and another combined together. It is a whole plant, and the more that we're understanding about the use of whole plant medicine, the more power that we're seeing in using whole plants to treat patients and leveraging the synergistic effect. And Dede's work from the Technion is look, it's in the early stages of development. We're years away from seeing results, but it demonstrates that we can't operate on this traditional pharmaceutical paradigm model where we're using one molecule to treat an indication. Just cannabis doesn't work that way.
Yet it's interesting. A doctor who is uneducated in cannabis would then throw up their hands and go, therefore I'm not doing it. And yet that doctor will go home in the evening and do some shopping. And when they're doing their shopping, they'll pick a good celery. They'll pick a ripe avocado with no blemishes. They'll know from being taught what a good plant is that will give their family nourishment. Now, we're not talking about cannabis as food, but that doctor has been educated previously that an avocado is not an avocado is not an avocado, and a celery can be variable in their quality, as can broccoli. And so it's a real interesting sort of mind flip that they're taught in drugs. They want to work in this very constricted environment. They are reticent to make that flip to a plant, probably because of the bad press regarding complementary medicines and things like that. And so they're reticent to actually realise that they're doing it already.
Well, I mean, these are excellent points, and it reminds me of a conversation I had this week with a colleague of mine. If you were to, let's say we didn't know anything about cannabis, it didn't exist, there's no stigma attached to cannabis whatsoever. It was just another plant somewhere in the world that hadn't been discovered, and a scientist one day discovers this plant and all of the therapeutic potential around it. We would jump on that as scientists and medical professionals because it has tremendous healing potential. But because of that stigma, because of that the fellow Henry, Mr. Anslinger, and the propaganda campaigns that were promoted by him and others in that area, we're dealing with a plant that is being treated like a criminal because it had a criminal caricature or straw man given to it, which is really tragic because it's just complete ignorance in its finest. But it hopefully, as I said, that Trojan horse piece, it hopefully will also illuminate that this, as well as other medicines which have also been demonized and criminalized, have tremendous healing potential. And maybe we haven't been told the entire truth, or maybe we just haven't investigated it, but we should be more open-minded to investigation. And we should accept that patients probably, I mean, a concerned mother whose son or daughter might be sick, ill, dying, they are going to thoroughly research how to heal their child more than any doctor because of that motivation. And I challenge anyone to counter that argument. But we can learn from those people, and maybe we haven't built the right tools and systems to empower them to track that data and put it into a centralized system where then, eventually artificial intelligence will be able to read that, and then you go to the doctor and get your genetic test taken, and it can cross-reference that with all the others who have contributed data, and we can go, this is actually what might work for you. I mean, we're years away from that, but the future of medicine is actually very bright. Cannabis is a wonderful, revealing plant that is going to hopefully illuminate the errors of our ways. And we may never see a situation like this in history where we have to put people in harm's way to heal, to benefit their loved ones.
Talking about medicine, and personalised medicine has been a term that's bandied around more and more in media, medical media. And it gels with not an edict, but a process, if you like, by the World Health Organization, that it's not just a needed thing, but it's actually vital. It's critical to medicine. Do you think cannabis is personalised medicine, or do you think it can indeed or should be individualised medicine?
I think it should be a medicine which is assessed on a case-by-case basis for patients. Ethan Russo released some work on endocannabinoid deficiency. Everyone has their own unique cannabinoid system, and therefore the cannabis medicine that works for me might be very different to the cannabis medicine that works for you. So I feel that we need to kind of get past this generalized blanket pharmaceutical approach where you are an average and you're not an average, you're an individual, and you need to be treated like that, and your medicine and your life plan should be reflective of that, because why I'm sick is going to be very different to why the person sitting next to me is sick, even if we have the same sickness. So our life situations will have directed us there, and we need to account for that. That's what my position is on this topic.
Thanks so much for joining
My pleasure.
us
Thank
on
you for
FX
having
Medicine.
me. Absolute pleasure. Thank you.
This is FX Medicine. I'm Andrew Whitfield Cook.